We appreciate you joining our session today. Today, we will be providing a practical webinar focused on making preclinical integration easier to implement. Our goal today is not to add another isolated resource, but to use Aquifer as a bridge between foundational science concepts and the way those concepts appear in patient care. Today, we have a range of attendees. We have basic science faculty, clinical skills educators, directors of clinical experiences across MD, DO, PA, and NP programs. Today, you'll leave with 5 ready-to-use implementation patterns in a realistic way to pilot one of them. Let me introduce you to my co-presenters and Aquifer peer trainers. First, Corky Lehman is the Adolescent Medicine Fellowship Director and former Pediatric Clerkship Director at the University of Cincinnati College of Medicine. And Kelsey Doherty is an Associate Professor at the University of Colorado's PA program. Aside from her role on Aquifer's peer trainer board, she also serves on Aquifer Consortium, Clinical Excellence, and PA Affinity boards. I'm Nicole Ferschke, and I will be the moderator for this session. Let's go ahead and get started. Here are the outcomes today for today's session. First, participants will see how Aquifer cases, integrated illness scripts, and mechanism of disease maps can connect mechanism with presentation. Secondly, we will identify one playbook that fits a curricular need that is currently faced by our attendees. Third, attendees will consider how to scale the approach without creating an unsustainable faculty workload. Today's webinar is designed as both practical training and strategic adoption. The session will include concrete examples, but every example should lead back to a repeatable implementation design. This slide reflects the responses that you had when we posed this question at the time of registration. So some of the things that we've identified through our pre-survey was that some of our attendees would like to be able to use basic science objectives to help to prioritize preclinical curriculum, noted high levels of student stress and anxiety that kind of lead to an adequate sense of preparation. And I think that that's something that we all face, and it's not specific to the students who are truly not adequately prepared. Also, delivering content to students much more than what we have them practice clinical reasoning, course mapping, time to stop and think about pathophysiology, and then some of the volume of foundational science information, and then ultimately feeling like learning feels fragmented. So many learners can recall a pathway or list the steps in a disease process and still struggle to explain why a patient has a particular symptom, why findings cluster together, or why one test is more informative than another. The gap is often not contact exposure, it's insufficient practice moving from mechanism to clinical consequence. Aquifer can help to provide that structure repeatedly. Aquifer cases give the patient context, while integrated illness scripts and mechanism of disease maps help learners to make the causal chain explicit. These repeated movement from mechanism to finding to reasoning is the central thread of this webinar. So to start off with, we'd like to start with a quick poll. Please choose the prompt that where a ready-to-use implementation pattern would be most helpful to you. And so what I see here is kind of a mix, but almost 30% of you have this, indicated that clinical skills and early exposure and foundational reasoning and organ blocks are both high priorities for you. So keeping that in mind, let's turn the conversation over to Kelsey to continue to discuss our preclinical playbooks.
Great. Thank you so much, Nicole. So let's shift the conversation now towards discussing some implementation strategies. And I think the key question to keep in mind as we start to discuss some of these preclinical playbooks is not simply what content is available on Aquifer, but rather what repeatable routine will help you and your learners use the content that's available with Aquifer well and to use it with consistency. Great. So I'd now like to introduce these 5 preclinical playbooks as sort of a menu, if you will, or a choose your own adventure. So these are organized by instructional need rather than by profession or course title. So a clinical skills course, an organ system block, or a transition course may each use Aquifer differently and may use some of these playbooks differently, even within the same program. So we're going to preview each of these playbooks now and highlight some examples and ways to implement these into a preclinical curriculum. So as we go through each of these, I would encourage you to think about your own institution and ways that some of these models may best address sort of a current pain point in your curriculum. So as we go through each of these playbooks, we're going to follow a similar framework of sort of this 4-step implementation cycle that's seen here. So step 1 is anchor. So anchor the activity that you're going to choose from Aquifer to an existing objective, skill, or patient problem. The second thing is to assign the most appropriate Aquifer resource as either pre-work or an in-class material that aligns with your chosen anchor. So we have found that by assigning these Aquifer components, such as a case, as opposed to just letting students kind of choose their own, it really helps to ground the activity as part of the curriculum and not just an afterthought for the student. The third step here is to activate the learning through something like a class debrief, a comparison task, a lab, or a facilitated discussion. And then finally, observe a small number of outcomes that show whether this integration of Aquifer content within your curriculum is working. So this could be as simple as monitoring for completion of a required activity, or as advanced as connecting the Aquifer activity to a reflection or a later assignment that the student has to turn in as a deliverable. And this cycle really prevents Aquifer from becoming sort of optional content or an optional content repository. And it also reduces faculty burden because the same architecture can be reused again and again across blocks and courses and cohorts. So here's our first playbook we'll discuss. So the clinical skills, early clinical exposure. And this playbook is really best for courses that are teaching history taking, physical examination, communication, SOAP notes, or oral presentations. And the case is really going to provide context for why those skills matter before the learners even encounter the complexity of real patients. So here's an example of a manageable setup. So assigning one case per physical exam unit, for example, with learners completing only the history and physical sections when appropriate. So pairing the case with a lab or standardized patient session as your anchor, and then asking learners to provide some type of deliverable. So a short oral presentation or a brief SOAP note that's related to that case. So an example of this is Family Medicine 11. It's a case of a patient who presents initially with knee pain, but later comes back with new wrist pain. And the diagnosis ends up being carpal tunnel. So we actually use this case at my institution at the University of Colorado. We have the students complete just the history and physical exam portion of the case ahead of class as pre-work. And then during class, they get into pairs and they practice a wrist musculoskeletal exam on each other. So this allows the students to connect the components of the case with the musculoskeletal exam of the wrist that they've already learned. Another example is to have students then practice after they've gone through a full case, or even just the history and physical exam part, they can write a SOAP note after the case and turn it in and receive some formative feedback. If you're using assignments, faculty should really scope the assignment explicitly and monitor the quality of learner performance over time. So one University of Washington School of Medicine co-clerkship pediatric director found that using this strategy of having students submit a deliverable like a SOAP note often uncovered students who were rushing through and failing to sort of glean important information from the case. It also helped the institution identify students who really needed help creating their differential diagnosis. So this really just illustrates the sequence we just discussed. So having a single integrated learning experience and really connecting them for the students rather than sort of separate, distinct assignments. So again, before lab, learners work through the case, identify the relevant history and physical exam findings. Then during the lab or during class time, they can connect those specific physical exam maneuvers to those findings. And then afterwards, having some type of deliverable. We sometimes have students actually give brief summary statements of the case to each other during class. Sometimes we call on someone to give a summary statement to the whole class. Or again, they can submit a SOAP note and receive some formative feedback. So this sequence really helps faculty use existing class time or existing lab time while adding that clinical context that's really going to augment learning. It also produces some observable learner work that can be reviewed for improvement across the course. So here's our second playbook. So foundational reasoning. So a lot of you commented looking for ways to really connect that foundational science to the clinical context. So this is really designed for organ system blocks that want learners to connect the pathophysiology of a disease with a patient presentation. So a case of the week model, assigning 1 or 2 cases per block, can provide enough repetition without overwhelming the course. So one example may be a case on cystic fibrosis for genetics. So there's a pediatrics 26 case that's a 9-week-old who's not gaining weight. Or maybe during a pulmonary course, having students review the mechanism of disease map for pneumonia that's shown here on kind of the right side of your screen. And then assigning an Aquifer case of a patient presenting with pneumonia. So for example, there's a geriatric 17 case that's a nursing home resident that develops a pneumonia. So after students have completed that pneumonia case on their own, find time to debrief the case in class and focus on the mechanism of disease of pneumonia from this mechanism of disease map and how it connects with that clinical presentation. So sort of using that class discussion to guide the students in connecting those dots. So I know it's very small on the screen here, but there's a section of the mechanism of disease map that has crackles, right? So talking to students about what are crackles, right? What do they tell us about what is occurring with the patient in terms of the pathophysiology of pneumonia? And then we'll talk in a little bit about this case debriefing template when we discuss the next playbook. So another way to do this is to use the causal mechanism, so something like hypoxemia as seen in this example, and compare it across several different disease states, such as pulmonary embolism, pneumothorax, and asthma. So they may all produce hypoxemia, but the causal mechanisms differ. So this would include having the students review the integrated illness script or the mechanism of disease maps for asthma, pulmonary embolism, and pneumothorax ahead of class, and then facilitate discussions with the students, such as what core concept is shared, where do the mechanisms diverge. This type of sort of compare and contrast activity moves learners beyond just memorizing disease lists, but towards that mechanistic reasoning. And these discussions and these sort of facilitator prompts can be synchronous, so they can be done during class time, or they could be asynchronous. So for example, having these questions on a discussion board that students can comment on, and the faculty member or facilitator can read those comments. So next slide. So still talking about sort of foundational reasoning, basic science, here's yet another way to integrate this. So instead of teaching a foundational science concept sort of in isolation and hoping learners can recall that and recognize its relevance, instead sort of begin with a patient problem that then creates a reason to learn or revisit the basic science mechanism. So in that case, I already mentioned of pediatrics 26, it's an infant that's not gaining weight, and the etiology ends up being cystic fibrosis. So have the students work independently through that case, and then actually develop their own mechanism of disease map that explains the basic science behind that clinical presentation. So Dr. Corky Lehman, who's with us here from the University of Cincinnati, in her pediatric clerkship courses, selects a common condition taught in a block And then a case is selected for that condition that can indicate the leading diagnosis or the differential diagnosis. And working in teams, students develop some top differentials for the case and then have to create their own mechanism of disease map for their differentials. So next slide. So now we're on to playbook 3. So this is small group team-based learning. And this really uses a flipped classroom model for the small group or team-based learning. So the assigned Aquifer case is completed individually before class, so required pre-work. And then class time is reserved for that clinical reasoning and taking deeper dives on specific topics from the case. So learners can document their decision points, questions they may be having, differentials as they're working through the case independently using something called the case analysis tool, which I'll show you more on the next slide. So then during class time, small groups can sort of compare what were some of their questions about the case, what were their differentials, and maybe points where their clinical reasoning diverged on the case. Then faculty or senior learners like residents can facilitate discussions rather than just going through the case again, but really taking deeper dives on those concepts. After class, learners can revise their reasoning pathway and identify a strategy that they can transfer to another patient problem. So the success of this model really depends on sort of visible required pre-work and then having that focused debrief in class. So if learners arrive unprepared, the discussion loses some of its value. At our institution at the University of Colorado, we have found over the years that following the independent completion of an Aquifer case with this class-wide debrief really allowed for some rich discussions. So the students could really hone in on their clinical reasoning that aligned with the concepts they were learning in class that week. So next slide. So these are two tools that are available for educators on the Aquifer website under educator resources. Really meant to be sort of plug and play models that you can add into your curriculum with not a lot of prep work ahead of time. So the tool on the left-hand side here is the case analysis tool. So this really captures how learners reason at key decision points and is useful when the goal is to examine the clinical reasoning process, especially for those early preclinical learners. So students complete this tool as they're working independently through the case on their own, and then the tool can either be turned in for formative feedback from faculty or can just be used for the student to work through the case. The tool on the right-hand side is the case debriefing tool. We sort of created this at our institution and use this every week in our curriculum. But it allows the student to organize key findings, the problem statement, their differential, and their plan for the case. We ask them to work on this independently as they're working through the case ahead of time. And then they bring it with them for the sort of in-class debrief about the case. And it allows for this really structured group discussion. With this, we also developed a debrief PowerPoint template that's also available on the Aquifer under Educator Resources that sort of is that plug and play model that can be easily adapted for any curriculum. So really the strategic benefit here, I think, is consistency, right? So when all facilitators are using the same prompts, the same language, small group quality is really less dependent on sort of individual teaching style, especially if you have a larger faculty. It is also less work for the faculty, right, to have to create something from scratch because the framework's already in place and can be easily tailored to the case and the sort of connection you want to make to a specific course. So I'll now hand it over to Dr. Corky Lehman, who's going to discuss our final two playbooks.
So our next playbook is the Bridge to Clerkship. It looks like in the poll, it was ranked as maybe the least wanted topic today, but I hope I can change your mind because this playbook can really help with transition friction. As a clerkship director, I see the students when they come, in those early weeks to months as they're going through right now. And it's pretty stressful for them. For many of them, I hate to say this, we joke about it here. It's like their first real full-time job. And then on top of that, they're still trying to learn. They have school requirements. So it can be a tough time. And we're hoping that you'll consider this playbook as it can help with, decreasing the friction in that transition, and not make it feel like, oh, here's just one more platform I got to learn as I, go into this hospital and have to complete all these other things on other platforms. So consider creating a low stakes orientation experience with 2 to 4 introductory Aquifer cases that'll allow the learners to build some familiarity before that clinical intensity really starts increasing. So consider if your school has an end of preclinical blocks or years, a summation course or a transition rotation, or even in those early clinical orientation weeks. Our school here in Cincinnati has a transition to the clerkship week. So it's a full week of orientation activities. And this might be a good place. Those places might be good for this playbook. You can use the course builder, a student's choice, to kind of figure out what options you want in the case decisions. I think it would be good to try to pick things that might be introductory, that could span across all clerkships, so students can think about a variety of specialties. So picking, cases like chest pain or abdominal pain, things that you're going to see on multiple different clerkships, and rotations might be a good one to start with. And then you've got to really think about the student expectations here too, like frame the work as readiness for getting there rather than we're assessing what you know and we want to see exactly what skills you have. It's really the goal is to get comfortable with the Aquifer interface, just get some practice with this and to start thinking clinically before you're really getting into these rotations. So it's not for mastery of the content. But again, one of the things is setting the expectations really clearly and then communicating well across the clerkships about which one you're using. Because we had that happen to us once where 2 different sets of people were using the same thing. So sometimes that's good to repeat, but sometimes it's not. So it's just something to think about. So how do you get there? Here's a lightweight model that can fit within an orientation or the period immediately before those clinical experiences start. So in week 1, learners complete the orientation and a wellness case while practicing navigation of the Aquifer platform and creating summary statements. In week 2, they complete a common chief complaint. And you have learner choice too, if you want, on which one they're finishing. And then in the closing, consider a brief reflection on this, like what skills are they going to transfer? What did they get out of this? Because I think sometimes our learners use these platforms and then don't realize truly what they're getting out of it. And then it just makes it seem like it's not just one other box to check. So like what reasoning routine, what documentation strategy, or what platform feature will that learner carry into that first clinical experience? Again, getting people familiar and getting confident, not mastering the content. In my orientations, I prompt the students a lot when I tell them to like go pick out a case and try it out. And I said, hey, you could practice with the case summaries. They're sort of like calling a consultant. You've only got a couple minutes on the phone to let that consultant know the main points of what the patient's symptoms are, and then also asking your specific question to the consultant. So one thing they could take away from that practice is sorting out pertinent positives and negatives to be ready to make those calls. And you can consider making other reflection prompts for the students about, how are you going to navigate documenting the information, or how did you put all that together? What was your scaffolding? What are some mnemonics you can use to help you stay organized in the clinical setting? All right, now here's another playbook that can be used anywhere. And I think this is great because it can introduce the cost consciousness, access to healthcare and equity as a part of clinical reasoning. It's not just, oh, we thought about that after all the care happened. So Playbook 5 is high value care and social determinants of health. We use these modules in our clerkship to go over some of these content areas, and they're really great. So, start short. There are introductory modules on both of these things that you can use in the first year, and fundamentals of doctoring is what we call it here, or other foundation courses. And then add to application cases. And, these are quick modules in year one. These are not going to overtax the students. And then you can connect them to certain things, like think about diabetes and food access, or hypertension with lifestyle and cost, vaccination, how much value that brings to population health. And then you can have students reflect on what were those social factors. What did the patient experience going through that case? And where did the cost alter value? I think in these kinds of these settings, I think a faculty debriefing, some sort of debriefing, helping the students out is really one of the key features too, because these concepts may not have received a lot of attention or time so far in the curriculum. So this is a really great place and way for them to start learning about these things while integrated into actual content about patient presentations and mechanisms of disease. Now, one thing I will say is we usually, try to get at that intro level. You may not want to get into like the highly complex payment systems, or really some of the system level things. Definitely want to get there at some point, but if they haven't had that clinical context yet, those kind of discussions might be a little too far. So again, bring it down to just introducing the topics and starting at that introductory level. Okay, so here's an example of how you could incorporate this. Let's say your school has an endocrine block. You can use a case on diabetes to integrate all of these things together. So I actually pretended I was the course block director today, went into Aquifer, used the AI assistant, because I'm a peds person. So I know those peds cases really well. I'm actually med peds by training, so I get the medicine part too. So I went in and I saw, wow, high value case 4 matches well here. We've got a patient with type 2 diabetes. It gets into some of the foundational science about insulin resistance, vascular injury, and then talks about nutrition and metabolism. It's got those clinical reasoning parts in there with the symptoms, the risk factors, coming up with like that diagnostic and medical management plan. But I think this is the neat part. Then it goes into the context and the value stuff. So how's that patient going to get access to the foods that they really need? What did these medications cost? Could the patient afford those things? And could they get access to care? Do they have transportation to follow up? And this hit home for me. I had some summer students working with me in research. They're preclinical, and they were like, wow, I see that like delivering, knowing what prescription to write is really important. But if the patient can't get to the pharmacy and get it, or can't return to get their next injection, that's a problem. Then it didn't work at all. I've learned all this and then nothing happened with the patient. So I think these integrations are really key and important as preclinical learners are coming into the clinical setting, so they're paying attention to these things. All right. Oh, I also wanted to say on that last slide, that took me with the AI assistant like all of 5 minutes to get that started. It was really quick. So, okay. We are now on to a poll. So we want to hear from you. So take a minute. What would make adoption of one of these playbooks easier? We want to know what supports you want that might accelerate implementation at your program. So would a curated case to course map help? Would ready to use student instructions be the thing you're looking for? Faculty facilitation guides, examples from peer institutions like we've been talking about today on this webinar, are helping to configure courses and reports. Okay, there we go. So it looks like the majority of you would like some faculty facilitation guides. That's awesome. Examples from peer institutions came in second, and a curated case to course map. All right. Well, thank you for those things. We're going to talk a little bit more on the following slides on some things that might be able to help you with some of those things. First thing is to think about is start small. I always think about these grand plans and then go, well, what the heck, let's start small so we can get something going, test it out, make sure it's happening. My research this summer has been a lot in quality improvement. So I'm really trying to keep those concepts of quality improvement in mind, and educational planning is very similar, I find. So, so you really want to not try to do so many disconnected activities all at once. So really start small, pick one course. Think about who would be a motivated faculty partner, and is there a clear curricular need? I can say around my institution, nutrition is a hot topic. I think it's a hot topic nationally. Is there something there that you could put into a course, and work on that? So, and what would that outcome be? What do you want to see happen? Is it students completing some assignment about nutrition? Is it working on their reasoning quality? Is it their confidence, or is it transfer of knowledge and skills? Pick a playbook. And again, use a repeatable pattern instead of several unrelated activities. Use some of the things that we've talked about today. And then after the first cycle, like in all quality improvement PDSAs, take a look at it and refine it before you expand it on. Try a pilot out first and see how it goes before you expand. And I wish I had had this when I was first a clerkship director and thinking about what should I do. It's good to think about things like what is going to be high effort with the learner and the faculty and all the different things that you pick. So think about the playbook and what can you realistically expect out of both your learners and your faculty. So the clinical skills playbook, low learner autonomy, not much for them to do. Faculty effort might be medium on getting that going and trying to figure out where it is and being present for debriefings. Foundational reasoning, also pretty easy for the student. Not a lot of choice, but they're getting it. The faculty effort, also probably in the medium bucket. Small group TBL playbook, probably a little bit medium on both sides because the students do have to come in prepared. And Kelsey talked about when the students show up and they're not prepared. It doesn't go quite as well. So the bridge to clerkship. Now, as you construct it, you can really make it a choose your own adventure for the learner too. So again, depends on how your school uses Aquifer, but it could be very learner centered, which some schools are looking for that gap to fill, wanting to put more of the choice into the learner's hands. And in that case, faculty effort's kind of low. You just say, hey, those are the ones we're doing, go at that, or I'll review the ones you did. Good enough. The high value and social determinants of health, these are quick modules. That playbook, I think, would be pretty easy to put into place pretty quickly and easy to do for the learners too. So, but think about those things as you're putting them into place. And it's not always, the best playbook is not always the most ambitious one. If it fits a current need and addresses it in a meaningful way, maybe that's the one to start with. It doesn't have to be huge. All right. So let's walk through on the next slide, kind of like, how would you go from this idea to a pilot without doing a giant curriculum redesign? We just went through that a couple of years ago here. So big undertaking, lots of meetings. But I think in your own clerkship and rotation, you can, and course, you can do things pretty quickly, especially if you're doing a pilot. So here's a 30-day launch plan to look at. So first week, think about what it is. What's your objective? What is it that you want to do? What's that gap you need to fill? Figure out what course that you could do that in. Who's your faculty partner? And redefine with them, what's our desired outcome? In that next week, select the case, check it out, get your student instructions ready. Think about how you want it to unfold and prepare the debrief if you need to, if it's not part of one of the Aquifer modules already. That next week, orient and launch. Again, introduce things to your students and really make expectations visible and clear. That always helps with students, of course. Then when you get into that last week, review what you've gotten back. Did you have learners submit work? Was it just about the quality of the debrief discussions? What was it that you thought was going to be your outcome? Take a good look at it and decide what you want to do with it. Is this good? We want to, go on and scale it up. Or do we just want to refine it, take a look at it, hopefully not abandon it. But sometimes you do come up with ones where you're like, it's a no-go. But This plan's intentionally short. Again, we don't want people to think, oh my gosh, I got to do this whole curriculum redesign. You can really get into some nice quick solutions if you step back a little bit and try something a little smaller to start. All right, before we wrap up, we would like you to take just a couple minutes to complete the survey. You can use your camera phone to scan the survey, and then the link to the survey is also in the chat. I think Mimi's going to put it there. So we'll take just a minute for people to fill out the survey. And now I think I'm handing it over to Nicole.
Thank you, Corky. So while we're waiting for individuals to complete the survey, I just want to do a quick wrap up on today's session with these key takeaways. Really, what I want to do is reinforce these 4 central messages. Start with the patient. Use a clinical problem and have your students take the foundational science and assign a purpose to that clinical problem. Secondly, make causality explicit by incorporating our integrated illness scripts and mechanism of disease maps. Additionally, you can use class time for reasoning, discussion, and practice rather than repeating content. And lastly, scale a pattern only after a focus pilot shows that it's useful and sustainable. As we, wrap up, if you want to kind of take a moment and identify which takeaway is most relevant to you and your curricular challenges that you face currently, you can certainly feel free to post which one of these takeaways is most impactful to you in the chat. At this point, we'd like to open it up for questions. If you'd like to enter into the chat which playbook or course made it that you think may be most useful to you, would be some good information to share. Also, thinking back to those initial responses that you gave during your registration, I think that many of the playbooks discussed today can be applied to a lot of those issues, specifically thinking about incorporating basic science and relating pathophysiology and foundational science, using the integrated illness scripts and mechanism of disease maps can be very helpful. I think that you can also help to decrease student stress and anxiety by incorporating foundational reasoning into your preclinical coursework. Then your learners may feel a little bit more confident going into that clinical space. And also, I think that integrating practical clinical reasoning can definitely be achieved using small group and team-based learning strategies. There is a QR code here that will take you to a web page that will allow you to request access to these playbooks, and Mimi can also put that web page into the chat if you don't mind. And then the last thing I wanted to mention is that we do offer curriculum consults. So if you find yourself having difficulty identifying the next steps or applying any of these playbooks to your program, which I did see a mention about that in the chat earlier, and also considering that in our second poll, the majority of you identified having a faculty guide would be helpful. A curriculum consult may also be a good way to start to incorporate these things. So if there's any questions, we would be happy to address those. Certainly, I believe you can unmute yourself or just drop them into the chat. And then, Kelsey and Corky, thank you both for your for your insight and help today. If either of you have any closing comments, I think that that's also appropriate at this point.
I'll just weigh in. I kind of put this in the chat, but I think there's lots of educator resources on the Aqueduct Aquifer website that we didn't even get to talk about today. But I think just taking some time to look through those, a lot of the cases in there actually have direct educator guides for how can I use this case in the classroom. And it has ready-made student instructions, ready-made faculty instructions, so really can be very plug and play. So I just would encourage people to look for those and check those out, so people are not reinventing the wheel, starting from scratch on these.
Yeah, thanks, Kelsey, for bringing that up for sure. Well, certainly, if there are not any particular questions, thank you all for joining us today and for listening. Please reach out and schedule a curricular consult if you feel like talking with the peer trainers would be helpful to you.